My name is Wekesa Davis. Wekesa Davis is a medical laboratory officer. And today I'm honored to take us through the topic that has just been projected there. We are talking of UHC. Kindly get me clearly. I'm not talking about UHC staffs. I'm talking of UHC as a program. Okay? So we are talking of intensified integration of laboratory diagnostics in UHC for realization of set goals. Let us put this into context. UHC, what comes to your mind when you hear UHC? UHC actually means all individuals and communities can access the health services they need, when they need, and where they need them, without suffering financial hardships. That is the basic concept about this. And it's based on 3 pillars. Service coverage, we are talking of equity. Is it available for all? We are talking of quality. Services should be of the highest enough standard. And finally, those services should be affordable. So we are talking of using healthcare services which do not put people to financial burdens. A critical yet overlooked component in achieving UHC is access to quality and timely laboratory diagnostics. I'm not going to look at UHC as an entire concept. I'm only going to pick out the laboratory aspect because that is what actually pushes us as colleagues. So diagnostics form the cornerstone of disease prevention, accurate diagnosis, treatment monitoring, and public health surveillance. Without them, clinical decisions making is compromised, leading to misdiagnosis, delayed treatment, poor health outcomes, and inefficient use of healthcare resources. So here we look at the UHC diagnostic specific goals. UHC has so many goals, and I do not want to go to what does not belong to us. Since majority of us are consumers of laboratory services, allow me focus to diagnostic specific goals. We are looking at universal access to diagnostics, ensure all levels of healthcare systems, including primary care, have access to essential laboratory tests as part of the WHO Essential Diagnostic List, EDL. I'm very sure we are familiar with the essential diagnostic lists. Quality assurance, we must establish and maintain good clinical laboratory practice and accreditation systems to ensure reliability, accuracy, and reproducibility of test results. Timely turnaround of results. A result is only good when it's out in time, okay? A quality delayed result does not serve a purpose. A quality timely result serves the purpose at its side. Then we look at affordability of diagnostic services. We should integrate laboratory testing into the national health insurance and financing schemes to remove out-of-pocket payments. I think we're going to have a very serious discussion about that. So integration of laboratory services into clinical pathways, ensure diagnostic testing is seamlessly linked to treatment pathways. Evidence-based treatment, we cannot run away from that. Infrastructure and workforce strengthening, invest in laboratory infrastructure, equipment, supply chains, and trained workforce to meet national testing demands. Equitable geographical coverage, we are talking of a tiered system of laboratory referral, okay? Whereby even a person or an individual in the most remote settings actually has access to the best services in terms of diagnostics. Data and surveillance, use laboratory data for disease surveillance, outbreak response, and health system planning, strengthening of public health outcomes. So, the global perspective to UHC. We look at the Lancet Commission on Diagnostics, the 2021 report. It estimated that nearly half of the world's population, particularly those in low and middle income countries, Of course, Kenya, we can't miss in that list. We are in the lower and mid-income countries. They lack access to basic diagnostic services. So this diagnostic gap undermines healthcare equity. It also ends disease control, and it diminishes the efficiency of healthcare systems. We have said we are moving to evidence-based treatment, right? That is the goal of each one of us. So if I can't get a result, if I can't get a test, it means the treatment options will be based on what? That leaves us with a question. So the World Health Organization Essential Diagnostic List, EDL, underscores diagnostics as a core pillar of health systems alongside medicines and vaccines. So in all this, where does then this report come in? In as much as many of these countries are struggling to implement these programs, we are missing out on something. Many UHC strategies still emphasize service delivery, financing, and human resources without fully integrating diagnostics into primary healthcare. I know that's where we have a problem, right? We have a problem, and that forms our gap in this aspect. So in the Kenyan context, we have looked at the global perspective in the Kenyan context at the national level. In 2023, BMC Health Services Research under Makori et al. Gave out some statistics. So they were analyzing the routine DHIS2 data and the 2018 Kenya Health Facility Assessment, and this was covering over 13,300 public facilities. These were the findings. One, the reporting completeness for rapid diagnostic tests, RDTs, was below 40. So if you can imagine at rapid RDTs, we are reporting below 40. How about these other technical tests? It also pointed out that test-specific reporting rates range from 9.6 to 89.6. Of course, that is individual. It varies from test to test. But then the annual demand for RDTs ranged between 2.5 and 11.5 million tests, leaving an unmet need of 1.2 to 3.4 million tests per year. And that is rapid diagnostic tests. These are readily available, right? Through the government program and other financial other players in the healthcare sectors. But if the unmet need of 1.2 to 3.5 million per year, how about if this is extrapolated to other serious diagnostic tests? Where does that then leave us? So this study highlighted a critical gap in diagnostic accessibility, especially for conditions like malaria, HIV, syphilis, and underscores the need for systemic improvements in facility level reporting, supply chain, and geographical equity. 2024 BMJ study using geocoded data from 13,373 healthcare facilities across the 47 counties. And this was done between 2018 and 2020, confirmed that RDT reporting completeness remained under 40% nationally. The highest unmet needs persisted in Turkana and in the coastal and western corridors, with marked disparities in access between the high and low capacity counties. Of course, this just highlights the deficit that we have at hand in terms of diagnostic capabilities. Capacity analysis for these countries, the diagnostics for universal health coverage, that is DX4 UHC Tracker 2023 pilot was done in Kisumu, Nakuru, Kilifi, and Nyeri counties, found that an overall diagnostic capacity of just 52.9 across public facilities, level 1, level 2 to 6. That is where we are. So service-specific capacity was even lower for non-communicable diseases, disease testing at 25.3%. and communicable disease diagnostics at 51.5%. That is published data, readily available to the public. So it only highlights the gaps that we have under our testing structures. Maternal health related cancer diagnostics stood at 59.3%, with imaging services such as CT scans concentrated in high level facilities only. That highlights the capacity that we have as at now. Of course, in this study, the rationale stands that given the central role of diagnostics in clinical care and healthcare system performance, the current under integration into UHC strategies represents a missed opportunity to advance equity, quality, and financial protection. This study seeks to examine how strategic strengthening for integration of diagnostic services can accelerate Kenya's progress towards UHC goals. Just quickly to highlight, the objectives was to assess the diagnostic gaps, which we have highlighted, to evaluate UHC alignment to the goals that we have, to strengthen policy integration, enhance service delivery, promote private sector engagement. Of course, that is a very key point because the government on its own cannot sustain 100% diagnostic capabilities. That is why we, as the promoters of this, we need to really focus on promoting private sector engagement. Support data-driven decision making. Significance of the study, of course, we have already identified that. We will not dwell on that. It's quite a long in here. I will skip some. Conceptual framework. We are looking at adopted WHO health systems framework emphasizing 6 building blocks: service delivery, health workforce, information system, access to essential medicine and diagnostics, financing and leadership, and governance. The framework guides analysis in diagnostic integration across systems components aligned to UHC. The empirical framework is grounded on evidence-based analysis of diagnostic integration within the UHC systems. We are looking at, it draws from multiple data sources and methodological approaches to assess the status, the barriers, and outcomes of integrating laboratory diagnostics into UHC. Assessment of diagnostic services coverage and utilization. Here we are focusing on empirical data on diagnostic tests available, coverage rates, and patient utilization patterns from documented works. We are reviewing what has already been documented. Okay? What has been documented and buried somewhere, we are uncovering it for us to have a discussion about. Of course, we had policy and funding analysis review. We are looking at empirical examination of national health policies, strategic plans, and budget allocations. Health system performance metrics, data on clinical outcomes linked to diagnostic services. We are talking of disease detection rates, treatment initiation times, and patient outcomes for documented journals, which are published and referenceable. Stakeholder perspectives, we are talking of documented or referenceable interviews and surveys from policymakers. These are readily available and can be referenced to. That is what we are looking at. Pilot intervention evaluation, we are talking of quantitative and qualitative data from pilot programs, implementing diagnostic strengthening initiatives within UHC schemes. We were assessing that. This is a mixed method design or kind of study, and we were majorly focused on a narrative approach. We are looking at already what has been published. It's in public domain. We are just reviewing it and bringing the context out to them. So the mixed method design, of course, it incorporated a narrative approach where we had to contextualize the historical evaluation and current status of diagnostic integration. And this narrative approach, of course, did not stand independently. It was supported by a systematic review, literature review, and this was aimed at identifying global and regional trends and gaps. We were also looking at policy analysis. We assessed the national health strategies and regulatory frameworks for alignment with WHO guidelines and essential diagnostic list. Retrospective analysis, of course, we are looking at documented stakeholder interviews which provided insights into barriers and facilitators of diagnostic integration, leveraging existing qualitative data without new primary interviews. We were just looking at what has already been documented for us. So, of course, it focused on selected low and middle income countries that had implemented UHC initiatives integrating diagnostic services. The analysis incorporated data and insights related to key stakeholders involved in diagnostic services, including healthcare system managers, laboratory personnel, policymakers, and patients impacted by these services. And again, I reiterate and say that this is already documented. We were just reviewing it and bringing out the gaps. Of course, I do not want to go so much into that because it's also based on systematic reviews. We are talking of reviews of quality documents. We are talking of reviews of stakeholder interviews that have already been documented, and review of health system data assessed by authorized reporting system. What did we uncover? What did we identify? And when we during this time, we were identifying gaps and also some enhancement points. What have they put in place? What has improved, or what has been put in place? So, with review of diagnostic services coverage and utilization, and under that, it falls under also budgeting as such. What are the gaps? The 2021 Lancet Commission on Diagnostics found that 47% of the global population lacks access to basic diagnostic tests. In 2023 WHO report, it indicated that diagnostics are directly involved in 70% of medical decisions, yet only 1 to 2% of national health budgets in low and medium income countries are actually located to laboratory services. We are the consumers of this info. We know where it pinches the most, right? In your individual work-related places, we know where it pinches the most, especially those of us in government settings. Because, of course, in private sector, we have a different story about that. So this data is actually pinned to our public settings. What enhancements have been put in place, or where do we recognize improvements? So there's a longitudinal study in Western Kenya showed that integration of multiple POC, point of care tests with regard to HIV, syphilis, malaria, and anemia at antenatal clinics increased comprehensive testing coverage from as low as 4.3% for syphilis and 27.8% for anemia to over 95% across the board. That is referenceable information. This is something that has been tried out, and improvement has been recognized. So if this is actually extrapolated to other areas of testing, we can see how important that will come in. A multi-county stepwise trial in Kenya and Zimbabwe found out that POC early infant diagnosis reduced result turnaround by 23 to 62 days and increased the probability of result return fourfold, 4.5 times. So if systems have been put in place, the turnaround time goes low. And when the turnaround goes low, it means the patients actually directly benefits from this. And what does this actually tell us? These enhancements in access and timeliness are strong evidence of improved diagnostic integration. If this is extrapolated to other diagnostic needs, this is just a sample aspect. What if we extrapolate it? Policy and funding alignment, we had an assessment of that, the gaps, review of UHC implementation strategies from Uganda, Kenya, Uganda, Ghana, Rwanda, and India found out this. Only Rwanda and India had clearly defined diagnostic packages in their UHC schemes, aligned with the WHO essential diagnostic list. In Kenya, that has not happened to date. And if it has happened, then it's not documented. But that is something that we should actually be moving towards. Kenya's UHC pilot 2018 to 2019 noted that poor integration of diagnostics in primary health centers was the key bottleneck. That is documented in MOH Kenya UHC Evaluation Report 2020. But it's buried somewhere. We do not focus on it somewhere. So enhancement, the WHO recommends leveraging existing HIV and COVID testing platforms to integrate additional diagnostics into UHC benefit packages. We have suffered this, so we know that we can also look at that as we look at this. A systematic review also shows an integrated platform, TB, HIV testing, maintained service level without increasing turnaround times and achieved better resource utilization. That is documented as such. Of course, there are studies that have been published pointing out health system performance metrics. I will just pick out the last one. Less than 28% of counties offered. I'm looking at a study in general hospitals in all 47 counties in 2018-2019 reviewed the availability of common and essential diagnostics as below. 0% of our counties at that time provided the full set of 27 cancer and anatomical pathology tests. 0% at that time. Number two, only 8 out of the 47 counties reported conducting at least 10 out of 27 tests during a 2-year period. Number three, less than 28% of counties offered even one cancer or pathology test consistently over 24 months. Those are gaps that we can't run away from. WHO Afro 2021 survey shows that over 60% of healthcare facilities in sub-Saharan Africa lack access to routine microbiology or biochemistry tests, severely constricting clinical pathways. Empirical data from the multi-country studies and WHO frameworks confirm that integrating diagnostic into UHC-led leads to improved disease detection, equity in care, and financial protection. On recommendation, of course, we recommend a formal inclusion of diagnostics into UHC benefit package. Number two, allocate adequate funding for diagnostic services. Number three is to decentralize essential diagnostic services. And here, it won't go without mentioning this. We want to expand the access to diagnostics by decentralizing testing capabilities to primary and community health centers. Most of these testing capabilities have actually been centralized at the county referral hospital. So we should actually start looking at that. We want also, a recommendation is to strengthen quality management systems. This goes without saying that at this age and era, we should not be having a county referral hospital lab that is not accredited. For the CMLTs that are here, that is something that you should start thinking about, that kindly ensure, even at the most basic level, have your county referral labs brought on board when it comes to matters accreditation. So integrate laboratory information systems into national HLIS. Of course, that is only meant to capture the information as such. I want to put something on that. Strengthen public-private partnerships to enhance diagnostics in UHC. We understand that the public sector on its own, independently, cannot sustain 100% diagnostic factors. That is a fact that we can't run away from. So that is where now the private sector players come in. Of course, when they come in, they bring on board innovation, they bring on board geographical reach, they bring on board and very improved turnaround time and quality. And this, in the long run, reduces public sector burden. Okay? On the public itself, most of these private sector players have a very serious network to the grassroots levels. If that network was to be leveraged upon by us as the consumers of this, it will really push us to greater heights. Thank you.